Hello, everyone, and welcome to the Axis webinar series. We have a great webinar tonight, Health and Fitness in X and Y Variations. And before I say any more about that, though, I'm going to have our webinar manager, Rick, share a few technical insights with the audience. Rick?
Oh, hello, everyone. Welcome to the webinar. I just wanted to tell you how to utilize the questions pane. If you look at your GoToWebinar control panel, you should see a little area down towards the bottom. And you can click on a little arrow and expand the pane. And it says questions. And then you should get a text box, and you can enter your question at any point during the webinar, and we will present those to Dr. Davis probably at the end of the webinar. Thank you.
Thanks, Rick. So everyone, we are really honored to have Dr. Shanlee Davis here with us, a pediatric endocrinologist, an instructor of pediatrics for the University of Colorado, and someone who is an important part of the Extraordinary Kids Clinic at Children's Hospital of Colorado. I've met Dr. Davis a number of times, and I think you're all in for a real treat as she shares her knowledge and insight with us here today. As Rick just said, you'll have an opportunity to ask questions by typing them in. We may not be able to answer all questions, or we may combine questions, and many of the questions won't be answered until the end of the presentation. Dr. Davis, thank you for being here tonight, taking time out to share all of this with us, and we're looking forward to hearing what you have to say.
Thanks, Robbie. Well, hello, everyone, and thank you for listening in tonight. As Robbie mentioned, we're going to be talking tonight about health and fitness in X and Y chromosome variations, and we'll just dive in at this point. So a little bit about what we're going to be starting with. I'm going to be using the term cardiometabolic health quite frequently in this talk, and so we're going to first talk about what is cardiometabolic health, what am I talking about, and some of the definitions that we're going to be using today. And then we're going to shift gears and talk specifically about health and fitness in X and Y chromosome variations, so what is known, and you'll see as well what is left to be yet discovered. And then really the take home, how to be proactive in ways to reduce your risk for these conditions that we know are more prevalent in X and Y chromosome variations. And then finally end with some research opportunities for you if you're interested. So I'm going to start off with some definitions. So I'm going to be talking a lot about risk factors or risk in general. And so talking about what is a risk factor, it's a characteristic or exposure that increases the likelihood of developing a condition. One example that I'm sure most people are familiar with, certainly a dermatologist would be familiar with, is that there are certain skin types that have an increased risk of skin cancer. So this picture here, you see a little red-headed girl with fair skin and freckles, and in the right situation, a lot of sunlight, she has a higher risk of developing a skin cancer or melanoma. It's important to understand that not everyone with this underlying risk will develop the condition, and that there are a lot of things that we can do to protect or lower our risk for developing these conditions as well. So knowing about your susceptibility or risk allows for preventative actions, proactive screening, timely intervention, and ultimately better outcomes. And so that's what we're trying to achieve here. I'm going to be presenting at sometimes some potentially scary things that people are at risk for, but understanding that we're doing this because we want to ultimately be able to be proactive in preventing, screening, intervening, and ending up with better outcomes. So where do risk factors come from? One of the most obvious things that people think about, and certainly is true, are our genetics or our DNA, our background that makes up who we are. And certainly in X and Y chromosome variations, this plays a huge role in the risk, and so we will be talking about that. But there are a lot of other things that contribute to our risk for different conditions as well. Age is one of them. Certainly toddlers have different risks than someone that's elderly, and our risks throughout our life change. Our hormones, as well as other proteins in our body, will put us at increased risk or potentially decreased risk, depending upon what we're talking about. What we put into our bodies, so the food that we eat, also what we do with our bodies, the activities that we elect to participate in, and then also medications, drugs, and other toxins that we might be exposed to, and many, many other things as well. These all confer different risks that we're going to be talking about. Okay, so we've talked a lot about risk, but at risk for what? So the idea of a cardiometabolic condition. When I say that word, cardiometabolic, we're talking about the big three disease conditions are type 2 diabetes, so the body's inability to make enough insulin to keep up with the needs, usually due to the body not being able to respond to insulin appropriately, or insulin resistance. Heart disease, also heart attack specifically, and then stroke or cerebral vascular disease. All of these chronic illnesses decrease quality of life, and they're also the leading causes of death in women and men. This is in general, in the general population. This is not specific to X and Y chromosome variations, but all of these conditions are what we call cardiometabolic conditions. So there are a set of risks or features that we see that put you at increased risk for developing these cardiometabolic conditions. And when you have these features, we sometimes call this metabolic syndrome, when you have a constellation of these features. So reviewing a little bit about what these features are, because we talk about them in the general labs that we get and the things that we would be monitoring for in clinic, include triglycerides and your LDL cholesterol. These are kind of the bad cholesterol features. So LDL sticks to the arterial walls, your blood vessel walls. They cause plaques to form, and they ultimately increase your risk of heart disease and stroke. HDL, on the other hand, is the good cholesterol. HDL cleans your arteries, it prevents plaque formation, and it decreases your risk of heart disease or stroke, so it's protective. So if you have a good cardiometabolic profile from a cholesterol perspective, you have low LDL, low triglycerides, and high HDL. And vice versa is true when we're talking about metabolic syndrome or high risk. So other things that play into metabolic syndrome include blood pressure. So blood pressure is the pressure of circulating blood on the blood vessels or your arteries, and high blood pressure increases your risk for these conditions that we're talking about. Abdominal fat or your belly fat is bad fat. So even if you're not obese, if you have a lot of fat that tends to accumulate in your belly, this makes insulin not work quite right in your body, and that's important for a predisposition for diabetes. And then ultimately, this high abdominal fat increases your risk for these cardiometabolic conditions we're talking about. And then finally, blood sugar. So if insulin is not working well in your body, at first your pancreas keeps up and produces a lot of insulin, but eventually, if the insulin isn't able to be high enough, the blood sugar will go up as well, and this is an early sign of diabetes. So all of these conditions or risks, the cholesterol, the blood pressure, the abdominal fat, and blood sugar, all of these things come together, and if you have three or more, you may get a diagnosis of metabolic syndrome, and what that means is that your risk for all of these cardiometabolic conditions is a lot higher. So the take home here are these are features that you can't see, but they increase your likelihood of developing cardiometabolic diseases. So what does this all have to do with X and Y variations? So I'm going to start here. This slide is on men with Klinefelter syndrome in particular. And there have been lots of studies done in adults with Klinefelter syndrome that have looked at cardiometabolic risk factors. And we're going to break it down a little bit about what's in the literature. This is kind of a summary slide of what we see. So about half of men with Klinefelter syndrome have metabolic syndrome, so have this constellation of these risk features that we just talked about. This is about 2 to 3 times higher than men in the general population without Klinefelter syndrome. So again, they have higher adiposity, higher body fat, particularly belly fat, higher triglycerides, lower HDL, so lower good cholesterol. And we have actually done a study even in children and seen that these risk factors are already starting to be present in boys with Klinefelter syndrome. About 20%, so 1 in 5, have type 2 diabetes, and this is about 2 to 3 times higher than the general population as well. importantly, most of the studies that have been done have an average age of 30, 35, and so although type 2 diabetes is very, very common in the general population, often it's in older age when you develop that, and we're seeing in XXY or Klinefelter syndrome that this might be developing earlier. And then about half of deaths in Klinefelter syndrome men are due to or linked to cardiometabolic diseases, so type 2 diabetes, heart disease, and stroke, or cerebral vascular disease. Again, these are the #1 causes of death in the general population as well, but that is 1.5 to 5.5 times higher in men with Klinefelter syndrome. So the take home here is that the burden of cardiometabolic disease in Klinefelter syndrome is high. So what about women with trisomy X and men with 47XYY? So the studies that have been done over in Europe that have looked at mortality, so death rates and causes of death, show that there is an increased risk of about 2 to 2.5 times of dying from cardiovascular disease in both women with trisomy X and men with XYY. Those are 2 different studies that they did. One very small study of a handful of girls with 47XXX looked at cardiopulmonary fitness, so kind of an exercise test essentially to see how the whole system works together, and found that this was lower in women with trisomy X. However, there is no other research done out there on this topic in women with trisomy X and men with 47XYY. Given that there is an increased risk of death based on these mortality studies, there certainly needs to be additional research done on these conditions. And I scoured the literature trying to find more things to be able to present to you today. But I think that overall, we can take a lot of the things that we know from XXY and at least some of them apply them to these individuals with trisomy X and XYY as well. So take home here is we need a lot more research in these conditions. So X and Y chromosome variations as a risk factor themselves, so the extra X or Y chromosome leading to this higher risk of cardiometabolic diseases. We know that there are probably lots of things that can contribute or increase this risk along the way, and maybe even need to be present in order for you to develop cardiovascular disease down the line. So your lifestyle, hormones, potentially other medical conditions can all play a role. We also know that there are probably a lot of protective factors that we're going to talk a lot more about today that can potentially reduce the risk of developing cardiometabolic disease. So diving deeper, we're going to talk a little bit on the research that is out there on XXY, and particularly in kids and younger individuals, so we can see understand a little bit deeper about how this is starting and therefore when we can prevent it. So I talked a lot about adiposity or belly fat, and this slide is going over that body shape is not just about obesity. So obesity, we are typically talking about your BMI, your body mass index. And down here on this graph or this figure, we see on the bottom axis across the bottom here, BMI, and 30 and above in adults is considered obese. 25 to 30 is kind of considered overweight, and then under that is considered a normal weight. And so you can see in this particular study done by Bo Jessen's group, published in 2006, they had lean, overweight, and obese adult males with Klinefelter syndrome, as well as controls of all of these weights as well. And so the controls are all of the black dots, the solid dots, and the Klinefelter's males are in the open circles that you can see here as well. And then fat is on this axis. So as you get a higher BMI, as you become more obese, you also have higher fat that you can measure, and this is a kind of a no-brainer. We know that obesity is consistent with higher levels of fat in your body. But what's interesting about this is that the men with XXY is this top line here, and it follows the exact same pattern, but it's significantly higher than the control males. And so for the same BMI, males with Klinefelter syndrome have 8 to 10% more abdominal fat than control males without Klinefelter syndrome. And so that's really interesting. There's something about how weight is carried, essentially, so more fat and less muscle, that we're definitely seeing when we look at the kind of body composition, as we call it. We were able to replicate this study in adolescents as well. This hasn't been published yet, but I presented it at a conference and presenting it again at a conference next month as well. But again, we have BMI down on this bottom axis and body fat on this y-axis here. And again, the open circles in the orange, boys with Klinefelter syndrome that are not adolescents, so 12 to 17 years old, they have higher body fat for any given BMI compared to the controls. And so there's, again, it's about body composition in there that we need to be diving in a little deeper. So this higher body fat seems to start pretty darn early. This was a study published in 2008, and they looked at 18 boys age 4 to 19 years old, so a pretty wide age range. And they found that they had higher body fat than what would be expected. And so they don't have a control group that they're comparing to, but these lines here on this graph are what we would consider kind of normal body fat lines. And so this middle line is the 50th percentile, and you can see that all of the if not all, of the squares and X's here are all above this 50th percentile, and so they all have higher body fat. We then looked at infants. This was a little pilot study that I'll talk about a little bit more in a couple of slides from now, but infants with XXY, we have 10 of them at 5 months of age, and this was 300 some typical male individuals at 5 months of age as well. And you can see that body fat is significantly higher in the XXY infants compared to the male infants without XXY. So the take home here is that body fat seems to already be higher in infancy, and it persists to adulthood. This was a study that Dr. Ross did, Dr. Judy Ross out of Philadelphia and Nemours, and she looked at kind of these other cardiometabolic features in boys with XXY as well. And her group was 4 to 12 years old, so before puberty. And these were all baseline, and she had 93 boys, so a really big study. And we published this a couple of years ago. And the take-homes from this, you don't have to read all of this whole table, but the take-homes are that BMI is not that impressive. These kids are not obese. However, they do seem to have more body fat. When you look down here about the fourth one and fifth one down here, you see percent body fat. And the SDS score is a standard deviation score. So normally you would see this at 0 if it was average. And you can see they're almost 3 times higher than average for body fat, which is really quite impressive given that they have a pretty normal BMI. 20% had both high triglycerides and low HDL, so a poor cardiometabolic profile from a lipids perspective or a cholesterol perspective. However, we did not see a high prevalence of high blood sugar at this age. But when we looked at a smaller group that had insulin levels measured, those insulin levels were often high, and so we did see some insulin resistance. Overall, in this cohort of 93 boys who were prepubertal, 40% of them had one feature of metabolic syndrome that we talked about a few slides ago. 27% had 2 features of metabolic syndrome, and 11% had 3 or more features of metabolic syndrome. So even in early childhood, they are meeting criteria for these concerning conditions. So then we did in adolescents with XXY. We looked at cardiopulmonary fitness. And so this is an exercise capacity test where we put you on a bike and we're measuring the oxygen that you breathe in and the carbon dioxide that you breathe out. And it looks at how well your heart, your lungs, your vessels, your muscles, everything all works together, essentially. So we had 30 boys with age 12 to 17 with XXY, and their exercise capacity is represented in this green box here. And exercise capacity is also called VO2, for those of you that might be familiar with this terminology, is on this y-axis over here. And you can see that the green box is significantly lower than our control males that don't have XXY. And when we looked a little bit deeper of what was associated with this low VO2 max, low fitness level, And we saw that adiposity, or fat mass, really was strongly associated. So the higher the fat mass up here, I think this is actually backwards. The higher the fat mass, the lower the VO2 max. And when we looked at physical activity, this is a measure of how active you are on a daily basis. The physical activity is associated overall with better fitness. And so the take home is that exercise does seem to be harder in boys with XXY when we measure it with a cardiopulmonary fitness test, but that regular exercise might improve this fitness and ability to do exercise. So a little bit deeper into physical activity and the cycle of and how to break it. So we know that sometimes boys with XXY, as well as kiddos with trisomy X and sometimes XYY, can have difficulties with muscle tone, having lower muscle tone, potentially difficulties with motor planning, coordination, and certainly fatigue is something we hear quite frequently. This all leads to physical activity being difficult and not enjoyable, which then leads to avoiding activity, sedentary choices, so choosing not to participate in physical activity, and ultimately deconditioning. This deconditioning then leads back to worsened fatigue and coordination and motor planning, or certainly not improvement in those things, and then leads to these cardiometabolic risk factors that we see as well. However, if we interrupt this pathway with daily physical activity, because we know that's a protective factor, that comes in here and really stops this cycle of deconditioning and cardiometabolic risk, and also can help improve a lot of the things that we see with practice and getting better with motor planning and coordination and endurance and fatigue as well. So that leads me to my top number one way of the 5 ways how you can reduce risk is getting more physical activity. The American Academy of Pediatrics recommends at least 1 hour of moderate to vigorous physical activity every day. This means that you get your heart rate up high for an hour or more every single day. And I will tell you that the large majority of American children do not do this. However, given that we know that there's an increased risk in X and Y chromosome variations, I think that we should really be truly trying to follow this recommendation that's set for all children, but especially important for individuals that have a known increased risk. We also know that there are proven benefits of physical activity, not just for cardiometabolic health like I've been talking about today, but also bone health and mental health and a whole host of other things as well. Physical activity is really needed to break that cycle of fatigue and deconditioning and leading to cardiometabolic disease. And so we need to jump in there and just do it. And really making age-appropriate physical activity a habit rather than a chore from a young age, so that we can instill some of these active lifestyles. So physical activity, hopefully in childhood especially, should be thought of more about as playtime, and then engagement in sports and even active family time, and then sometimes some therapies as well. Occupational therapy, physical therapy, and things are all examples of ways that physical activity can start even in childhood. And so we're not necessarily talking about an exercise program at the gym. It can look a lot of different ways. In clinic, I get a lot of barriers thrown at me of why exercise or physical activity in general is just not feasible, not possible for kiddos with X and Y chromosome variations. And some of the barriers that I hear I've listed here, and I'm going to go over a few of my kind of rah-rah pep talks for trying to overcome some of these barriers. So one of them is that sometimes situations that you're getting physical activity can be overstimulating, such as being at a game, if you're participating in a team sport, or even a class at a gym or things like that. And there's definitely some social aspects to physical activity in those situations as well. And some kids have challenges with that. And so I think that thinking about different environments in which you can have a positive experience with physical activity without necessarily having an overstimulating experience is important. So smaller settings, potentially considering private lessons rather than classes or group lessons, really trying to have an active home life and family life, that you're doing things in a comfortable environment that the kid is really already familiar with. And then also occupational therapy and physical therapy. These are usually one-on-one sessions that can kind of take out some of that social aspect and take out some of the overstimulating aspects that physical activity can have. The next one, physical activity is hard. Yes, physical activity is definitely hard. And it seems like from the study that I just presented that it might even be harder in kids with X and Y chromosome variations. However, we know that like anything that's hard, if we practice it, we get better. And repetition and muscle memory certainly makes things a lot easier. So you have to start and things then get easier. Also really considering level appropriate activities. So not just age appropriate, but level appropriate as well. And they may not be at the same level as their peers, and maybe picking activities that are a little bit more likable or not necessarily easy, but can engage them a little bit better. And then just really good positive reinforcement all the time. It doesn't matter if you're not the best at things, but really trying your hardest and putting in the effort is what should be reinforced. There's no motivation. I don't want to do it. I'm just not the active kid. I'd rather kind of play more activities that are mellow and not running around. I think that a lot of these kiddos, in my experience, seem to need more active encouragement to participate in physical activity. So thinking about, you know, actually turning off the TV and not giving them other things to do, actually telling them you have to go out and play, you know, doing this. Sometimes it's okay to not like it, but that motivation factor sometimes needs to be stimulated from the outside. And then also we found success with actually scheduling with a physical therapist or a trainer, because then they can provide some additional motivation as well. And certainly if it's in the schedule and you're paying for them, that's motivation to get them there and to go as well. And then sometimes engaging siblings or friends to do more active activities, particularly with the kiddo that is less active, is a good motivating factor as well. Then I'm not good. I'm not good at swimming. I'm not good at running. There's a lot of different ways to get physical activity and trying different things, and sometimes something might click and sometimes something might be, you know, you might be good at something at one point or okay, and then it might get harder as different level, as you go up in levels. It's okay to try different things and don't just give up. There are certainly also non-competitive options, and if that whole competition or comparing yourself to others is the limiting factor, really try to take that out of the equation and engage in non-competitive things. And then finally, just really encouraging, again, that positive reinforcement of doing your best. It doesn't matter what other people are doing. Fatigue is such a common complaint that I hear, and I'm trying to do more research into deeper understanding of what is behind this. But some kind of at this point, what I encourage is that getting enough sleep is important, and napping is okay, even if you're an adolescent or an adult. Sometimes naps are helpful and needed and really can counteract some of the fatigue that we see a lot. And then also considering talking to your physician, because there are a lot of different medical conditions that can contribute to fatigue that we'd like to rule out and make sure that you don't have signs or symptoms of. Things like sleep apnea and restless leg syndromes, or getting poor quality of sleep, for example, but then also a lot of other health conditions as well that can contribute to fatigue. And then finally, we know that that's part of the whole cycle of deconditioning, is that you get more fatigued if you're not using your muscles. And so conditioning itself, so exercise itself, helps combat that fatigue too. Anxiety and inattention or other behavior things that might interfere with the ability to do sports or other physical activities. I think that some counter situations to this is prepping them for new situations. If they get anxious in new situations where they're not sure how to deal with new information and things like that, you know, going over the rules of the game sort of thing, showing them what's going to happen before they go. And then also proactively communicating with their coach or their instructor or their teacher about what does anxiety look like in this kiddo. And, you know, if they act like this, that really means that they're pretty anxious about this situation. And so How do they combat that, and how do they, ahead of time deal with those situations? And then certainly sometimes there's indications for medication as well if the anxiety or inattention is interfering with life activities. Time is a barrier for all of us to doing physical activity. That's certainly not specific to X and Y chromosome variations, but I think that for all of us, we need to really block exercise in our schedules every day and make sure that it's part of our daily routine. Also, especially in the adolescents when they're in high school, and it seems like the homework load is really, really heavy for a lot of kiddos, and sometimes hours and hours of homework after school. And so I think that, even if you can't carve out a whole hour to do physical activity, sticking in some homework breaks where you're, gonna do jumping jacks every 30 minutes of homework or whatever it is, or going for a walk or a run or a bike ride in the middle of, trying to get some movement in and not just sedentary activity. And then also exercise with dual purpose, so chores, walking the dog, that sort of thing, where you're killing two birds with one stone, as the saying goes. And then if you really have no time, active weekends are helpful as well. So your week schedule might be completely packed and there's just no way that we can get in an hour of activity every day. At the minimum, you should be making sure that your weekends are as active as they can be. And then finally, not a priority. I think that for a lot of things, there's a lot of conflicting interests, and a lot of some kiddos with X and Y chromosome variations have a lot on their plate, and the exercise is kind of not something that comes to the top. However, hopefully from this talk, you're getting that there's kind of a background hidden risk here, that you're not going to see an F on a transcript or a grade, knowing that you need to pay attention to this area, at least in childhood, but that this background risk is there and it's hidden, and we know that there are numerous benefits to exercise that we can counteract. Okay, so the next question I get is, what sports or activities did you enjoy, or what sports or activities should my kiddo do? There was actually a post on Facebook, one of the Facebook groups for X and Y chromosome variations, just a couple of days ago, and so I did this little word cloud thing. This is not a research thing at all, but the responses to the question, what sports or activities did or do you enjoy most for individuals with X and Y chromosome variations, and the bigger the print, the more times that it was mentioned. It could have been mentioned as I hated baseball, but I just put them all in here. And really, these are similar to probably what we hear in the clinic as well. I would say that we have a lot of individuals that do a variety of sports. There's not certainly one or two things that are, the sport for X and Y chromosome variations. There's a lot of things listed here, right? But you can see that some of the things that come up are kind of more individual sports, and potentially not as much in the aggressive team sport sort of thing, with soccer kind of being the exception here. But a lot of golf and swimming and gymnastics, where you still can participate on a team but have a lot of more individual responsibility and not a lot of having to react quickly to situations and things like that, seem to be particularly of interest to kids with X and Y chromosome variations. But again, you can do anything and everything that you desire. So considering what their interests are and what their strengths are and what their goals are, and then also certainly what is available in your location. If you're, live in Florida, you probably can't do a lot of snowboarding on a regular basis, and so thinking about those things, obviously. All right. Robbie, are there any questions before I move on to the next thing about physical activity? I mostly just want to know that you can still hear me.
We can hear you just fine, Dr. Davis, and at this point we don't have any questions, but I do want to take just a moment here to interrupt and thank our two major sponsors for the webinar, which is our Endo Pharmaceuticals and Roche Diagnostics. But I will let you know if any questions do come up.
Okay, sounds good. Thanks, Robbie. All right, so the second of the top 5 ways I think that we can think about reducing risk for these conditions is making sure that we're putting healthy things in our body. So your job as parents, if parents are on the line here, is to provide a variety of fruits and vegetables and whole grains and lean proteins for every meal. I get the question a lot, should they be on this supplement and that supplement? Really, no pills can substitute for wholesome, nutritious food. That being said, if you have a really picky eater who's just not eating, will not eat a good variety of foods, then you're potentially missing some key nutrition and ingredients. A multivitamin or potentially targeted supplements might be indicated, so I would talk to their doctor about that. Overall, the idea is that we want to limit high sugar, high fat, high salt, and processed foods. It's not that we can't ever have them, it's just that these are things that should be a minority of our diet rather than the majority of our diet. And then finally, avoiding smoking, drugs, and alcohol, particularly as they get older. Smoking is one of the worst things that you can do to add to your cardiovascular risk, and so eliminating that, not ever doing that is key. Down here at the corner, I have choosemyplate.gov. If you're kind of lost in this, like never really understood nutrition, didn't understand what kids should be eating, this is a good resource that I send my patients to, because it goes over, exactly kind of portion sizes for each age and what's expected, as well as what are good examples of things that are healthy and unhealthy, and goes through that too. So choosemyplate.gov is a good resource for healthy eating in childhood and adolescence. All right, the barriers that I hear from this about the putting healthy things in your body, particularly in X and Y chromosome variations, is sometimes we see an increased risk of feeding difficulties, particularly in early childhood, and occupational and or feeding therapy can be helpful in these situations. I also want to make sure that we're ruling out other medical problems that could be causing feeding difficulties. So food allergies, sometimes kids have allergies to food, and so they're resistant to eating those types of food, and that is something that needs to be ruled out so that we can treat that appropriately. And then working, just on consistency and working towards a goal. I think one of the biggest difficulties with this in early childhood is that parents get in a pattern of, I'll just feed them whatever they will eat, and then they eat like 3 things in their diet and never have a whole lot else. And so introducing new foods in consistent, in a consistent manner towards healthy eating is important. Failure to thrive is something that we see sometimes. It's not super common, but we certainly can appreciate that in X and Y chromosomes as well. So this is basically they're failing to gain weight and to grow like we would want them to in childhood or infancy. And I think that most failure to thrive does deserve a medical evaluation to make sure that we don't have an identifying cause that's treatable to figuring out why they're not gaining weight or growing like they're supposed to. And then knowing that high-calorie foods certainly will help with failure to thrive. That's the whole goal, is to get more calories in, but we want them to still be nutritious. And so often I see parents, again, giving whatever they can, whatever the kid will eat that's high-calorie, a bunch of sugar. I have in here, avoid high-fructose corn syrup supplements. Things like Pediatric are often recommended by physicians to give to kids with failure to thrive. But I think that if we can try to substitute some higher calorie but nutritious foods without that high fructose corn syrup, I think that gets us in a better position to avoid some unhealthy eating habits that can develop in these situations. Sugar cravings is another thing that I hear a lot, particularly in XXYY individuals, but possibly some other conditions as well. I have stories of, finding hidden candy wrappers in their rooms and having to lock cabinets and things like that. So I definitely think that there is something real to the sugar craving thing. But I would say that having kind of adopting a model that sweets are treats, meaning that they're not an everyday thing that we have. And it's not that they don't get them ever, it's just that they're not a routine part of your diet. And then also kind of substituting some other things that are still sweet, but maybe wholesome, like fruits, berries in particular, might kind of help that sweet tooth craving, but be able to still be healthy and not just candy or soda. And then really eliminating access, or certainly limiting access to these things as well. So you don't put it in the kids' hands to stay out of the cabinet. They're just not even there, or potentially locked. And then finally, picky eating or sensory texture issues and things like that we certainly can see as well. I think, again, continuing to offer a variety of foods for every meal, but then also getting creative and fun. And so what do they like to eat, and how can you make this more healthy? If there's a sensory issue where they don't like meat, you know, trying to figure out what kind of other protein sources they can get where they're still able to get the nutrients that they need without having the issue of the sensory problem. And then trying to minimize meal drama as well. Don't be a short order cook that gives them their favorite food when they don't eat their plate. Don't have a big battle at dinner every night. And if some of these things are happening, I think meeting with a feeding therapist or at least talking to your pediatrician can be helpful. All right, number 3 is maintaining a healthy weight. So this is a growth chart here. I think understanding how to read a growth chart is really important. Your age is down here on the bottom axis here, and then in this growth chart, it's BMI. So how much you weigh compared to how tall you are. And again, we have a BMI up here of, you know, above 30 in adults, and in this case, above 27 in these kids or whatnot is considered overweight and obese. And then down here is the healthy weight, and here is the underweight. I think it's important to recognize that we still don't have all the answers, but metabolism and X and Y chromosome variations may be different. And so they may not need as many calories as siblings or other kids without these conditions, or they may need more depending upon the situation. I already kind of said weight is compared to height for BMI. And if your BMI is high, I think it's really important to take control of the situation. So making a plan with the doctor of how we're going to address this, getting the whole family involved in lifestyle changes, and then really sticking to it and making them habits that are healthy and celebrating those successes. This is a common growth chart pattern that I see in boys with XXY in particular, but I've also seen it in other X and Y chromosome variations as well. This is their age down here in the x-axis and their BMI again, and you can see that they're really quite low on the scale. All these blue dots are different visits. They're almost in the underweight category here in childhood, and I see that frequently, that they're underweight in childhood, and people you certainly aren't thinking necessarily about a healthy diet and exercise and you know, making the right choices and instilling those healthy habits. And then all of a sudden, as you get into young adulthood, this BMI skyrockets way up. And this last point here, he was 21 when he came back to us, so it's off the growth chart, but he's solidly into the obese category. And this is something that I see quite frequently, that we see this rapid rise in their BMI in late childhood, early adulthood. And so trying to recognize that even though you're kind of on the low side of the BMI curve down here, that still might not be a healthy place. Still having healthy habits is really important. All right, number 4 is treating any medical risk factors that might be present. So if any hormone deficiencies are present, particularly in XXY and XXYY, we know that testosterone deficiency is kind of one of the features that we see, and testosterone replacement can certainly be helpful, and I'll show a couple of slides on studies on that next. And then also prompt diagnosis and treatment of other medical conditions as well. So asthma and allergies are things we see commonly, sleep apnea, anxiety, and depression. These don't necessarily need treatments that are specific to X and Y chromosome variations necessarily, but they need to be addressed and treated promptly, because this overall health really makes a difference in your risk factor as well. All right, a couple slides on the role of testosterone. So testosterone is an anabolic steroid, meaning it builds up muscle and decreases fat stores. We know that when there's testosterone deficiency, so not enough testosterone around, that this leads to increased body fat, adiposity, which then leads to all of these things that we've been talking about: diabetes, cardiovascular disease, poor fitness, and also chronic inflammation, which is a cycle as well that I'm not going to get into a whole lot here, but can lead to some other conditions as well, including cancers. So looking at testosterone throughout the lifespan, this is in infancy. We have a testosterone surge normally, so sometimes referred to as the mini puberty period. And then testosterone levels are pretty low in childhood and then pick up again starting in puberty and into adulthood. When we look at XXY and other conditions with an extra X chromosome, we see that the same pattern happens at about the same timing. However, the testosterone peaks are probably a little bit lower. There's not a ton of studies done in infancy, but overall we see that there's probably a lower peak in infancy. Probably not, a ton of information in childhood because our labs aren't that great to be able to assess testosterone at such low levels that we see in childhood. And then in puberty, we see this pickup typically, but often will either plateau too early or sometimes even decline. So when to start testosterone, I'm going to breeze by this. There are multiple different approaches of how you start testosterone, and there are no standardized guidelines of how you start testosterone in XXY. We're working on that with Access to and the ACRC to put together some guidelines for this and other things as well. But a couple of different time points basically in this trajectory where we might be considering starting testosterone, and each endocrinologist or urologist might do it a little bit differently. Pointing out here that really this prepubertal testosterone, all measurable hormones are typically within the normal range. Even though they might be a little bit below average, they're still usually within the normal range that we would expect. And so we're still doing studies in this area to figure out if and when testosterone should be given. So looking a little bit at testosterone at that research kind of childhood period that I just mentioned. So in that study that we looked at infants with XXY, we had 20 kiddos participate in this study that we had 10 of them get testosterone and 10 of them did not get testosterone during infancy, that mini puberty period or that initial spike. And what we see here, this is change in percent body fat Z-scores. So how much fat that they gained during the study period, which was a total of 3 months. 0 would be following a normal curve. So you would be growing normally, just staying at the 50th percentile essentially. Or if you're at the 20th percentile, staying at the 20th percentile. You can see here that the kiddos that got testosterone essentially followed that normal curve. They were at 0. However, the kiddos that did not get testosterone in the green here, they had a gain in their body fat percentage by nearly a full standard deviation or a full Z-score. So this seems to be a time that body fat was accumulating. Although all of them that when they enrolled in the study, they had normal body fat on enrollment, by the time that they were 5 months into the study, this is similar to the slide I showed before where we had 10 that didn't have testosterone compared to the normal controls, you can see that they're significantly higher at 5 months of age. However, the kiddos that receive testosterone are almost identical to the typical XY boys at 23% here. Looking at breaking this down into other how body composition in general changed with testosterone in this infant study, we can see that really this middle one here where it's fat-free mass, which is your lean muscle mass, that has the biggest difference between the treated kids and the untreated kids. And so the treated kids gained a lot more lean muscle when they received testosterone compared to the kids that did not. And that's what we expect as an anabolic steroid. It builds up muscle. Their fat mass did decrease a little bit, but not, I shouldn't say decrease, their change in fat mass, they're all growing kids. And so they're going to be gaining actual mass or actual fat mass, but their gain in fat mass wasn't quite as much as the kiddos that didn't receive treatment, but really this wasn't statistically different. It's really this fat-free mass that was driving that. Back to Dr. Judy Ross's study where she looked at children, so 4 to 12 years of age with XXY and looking at body composition when treated with oxandrolone, which is a testosterone relative. At baseline here, this is time 0, way over here, the fat mass or the percent body fat was really quite high. Again, 0 would be average when you're looking at standard deviation scores. So 0 would be the 50th percentile. And they're a full standard deviation above the norm here at baseline. And then after 2 years of treatment with oxandrolone, we see that the kiddos that received placebo had no change essentially in their body fat percentage, but those that received oxandrolone, the testosterone relative, had a significant decrease in their body fat percentage. It still doesn't get all the way to 0 here, so it's still not average for boys their age, but it is an improvement. So the take home really here is that testosterone treatment does change body composition even in childhood. Another one here of the adolescents that we see that were on testosterone versus those that weren't. Again, we see that there's a slight decrease in a slightly lower fat mass percentage, and really it's coming from the fat mass here, as you can see. Okay. So in summary, testosterone for cardiometabolic risk, and this is again specific to XXY and XXXY and XXYY conditions. Our interventional studies are limited overall. We don't have a lot of them, but overall it's pretty convincing that body fat does decrease when you give testosterone. However, it's less consistent what testosterone does on other cardiometabolic risk factors. In fact, it actually decreases your good cholesterol or your HDL, and so there's kind of a yin and a yang and some good things and some bad things. And I want to emphasize that testosterone is not a miracle drug. It's not just an issue of they need testosterone and then they'll be all better. I think that this underlying risk is something that's also from the genetic perspective as well that we need to be conscious of. And there's no current consensus on when to start testosterone, as I mentioned before. So, and then the final fifth of the top 5 ways that you can reduce risk is to advocate for yourself. So despite how common X and Y variations are, many professionals do not know about them and certainly don't know details about them. So I encourage my patients to avoid Dr. Google, but I do want them to read up on reputable sources. And so the Access website, genetic.org, has a lot of good resources posted on there that are readable for parents and that you can bring to professionals as well that are taking care of your kiddos. Discuss known risks that we've been talking about today and make plans with your doctors about how you're gonna address those risks. Understanding the side effects of any medications that you're on, because some of them can increase that risk profile as well. And trying to incorporate healthy choices even into academic plans or work plans. So sometimes IEPs or 504 plans can maybe elect to participate in a physical education class a little bit older than it would otherwise be offered and things like that, and certainly not Xing out the physical education classes in IEP plans. And then also enlisting the help of others as well, so friends and family and therapists and a whole bunch of other people that you can get on your team to be able to make this less burdensome and actually kind of fun. So in lieu of consensus guidelines, my approach to cardiometabolic screening, at least for XXY, I would say that we need more research in the other X and Y chromosome variations before we start routinely screening all of these things. But what I do in boys with XXY, everyone should be getting a height and a weight at least annually. Everyone should be getting a blood pressure at least annually. And then a cholesterol panel, I do one set between age 9 to 11 years of age, and then every 1 to 3 years, depending upon the risk and what that baseline lab was. And so if you're obese, I would be getting it every year. That's in the guidelines. It's a little bit more clear, but non-obese kids, just with the risk factor of having XXY, I might be getting every 3 years or so. A hemoglobin A1C is a screen for diabetes. This is essentially an average of what your blood sugars have been over the last 3 months. And again, it's in the guidelines that if you're obese, we get it every 10 years. I would say if you're not obese, I'm not routinely getting this unless there are other symptoms or risk factors like a family history of diabetes and there are signs on physical exam that may make me think that. Liver function is not something we talked a lot about today or at all today, but part of that increased abdominal fat is that the fat can end up in your liver, called fatty liver disease. And this is something that has not been researched very well at all in any of the X and Y chromosome variations, but we're hoping to learn more about. And certainly we know that anytime that it is present in adults at higher rates for XXY anyway, and so and it's generally common in the general population, particularly with obesity. And so I usually will get this liver function test every 1 to 3 years, again, depending upon risk, every 1 year if you're obese and less frequently if you don't have other risk factors. And then vitamin D is kind of fading in and out of popularity as far as whether or not we should be screening it and whether or not it has any consequences. We see a lot of vitamin D deficiency in the general population. And whether or not that actually correlates with or causes any problems is some people shrug their shoulders about, but I would say if your diet sounds like you might not be getting enough vitamin D, or you spend no time in the sun sort of thing, vitamin D is something that I might consider checking as well. All right, moving on. No more top 5 things of how you can prevent cardiometabolic disease, but a little plug to get involved with research so that we can have more evidence-based guidelines of how we should be screening and preventing and treating these conditions so that we can kind of erase some of those statistics that I presented at the beginning. So for those of you that don't know, clinicaltrials.gov is a website that you can go to look at a whole bunch of studies. Any intervention study that is done, so they are giving a treatment of any sort, needs to be registered in clinicaltrials.gov. And a lot of other clinical trials, even if they're not giving a treatment, but just studies that are monitoring health and development as well, will register in clinicaltrials.gov as well. So you can go to this website and click on this Find Studies, and this will pop up here, and you can search specifically for the condition or disease that you're interested in. So you can search XXX, or type in trisomy X or triple X, or all of the other conditions that you might be looking at. I would say you can limit it just to the US if you want, or if you're willing to travel elsewhere, you can leave it open and hit the search button. I would say that there's not a ton out there right now, but certainly something to visit every once in a while if that's something that you're interested in. And then Access also has on their website, genetic.org, under this resources tab here, research opportunities for families, and most of the clinics that are participating in research for X and Y chromosome variations list their studies here on the Access website, and so that's a really good resource for families who want to get involved with research as well. And then a quick plug for the 3 studies that we currently are now actively recruiting for. The Extraordinary Baby Study is funded by the NICHD to a grant to Dr. Tartaglia. And this study is essentially trying to get a better idea of the natural history of babies with all X and Y chromosome variations. The idea is that we're taking babies with a prenatal diagnosis and enrolling them within the first year of life, often before we see anything different whatsoever. And we're looking at factors that may be protective or risk factors to develop some of the conditions that we know are at an increased risk for babies, children and individuals with X and Y chromosome variations. We're then also hoping to be able to look at what predicts some of the outcomes that we're looking at, and then ultimately what screenings and treatments maybe lead to those better outcomes as well. The aims of the study are multiple. I think I'm going to fly through some of these. Essentially, we're following these babies for several years, for many years into childhood, and looking at, again, these risk factors, early predictors. We're looking at neurodevelopment. We're looking at health outcomes. And we're also creating a biobank of DNA, RNA, and urine and stool to be able to use for future studies as well. We're enrolling 20 infants as well as their parents, all with a prenatal diagnosis of an X and Y chromosome variation, and they have to enroll within the first year of life. They can either come to our site here in Denver, or they can go see our colleague, Dr. Judy Ross at Nemours in Delaware, who's our colleague site participant in this as well. Again, you have to enroll before a year of life, so even either at the 2-month visit, the 6-month visit, or the 12-month visit, and then we follow you for several years after that. It's about a 1 to 2 day visit where we're collecting this information, standardized measures of development, physical exam, and a history. We're doing a special body composition assessment with something called the P-POD, which measures your fat and your non-fat mass in babies, and it's completely non-invasive and just a special scale, basically. We're looking at some quality of life outcomes, and then again, the samples that I mentioned that we're collecting. The next study that we're doing is TESTO, which is testosterone effects on short-term outcomes in infants with XXY, and this is also funded by the NICHD through a career development award that I received. And the aims of this study is to study the safety and efficacy of testosterone therapy during the mini-puberty period of infancy on physical development, body composition, and early development. So again, we're looking at, if this is the testosterone cycle through life, we're looking at this mini-puberty period here, and we're looking to try to answer if this blunted surge is contributing to health and developmental differences, and if giving testosterone helps. we're going to kind of fly through this because it's not all that important. We're enrolling 60 kiddos. It's a double-blind study, so neither I nor the parents will know what treatment group the kiddos are in, at which time they're getting treatment, essentially. And it's prospective, so we follow them for 6 months. Again, we're enrolling 60 kids. Half of them will be randomized to this testosterone first arm and then placebo second. And half of them will be randomized to get placebo first and then testosterone second. So they all get testosterone as part of this study. It's just a matter of when they're getting testosterone, either in these early first 12 weeks or the second 12 weeks. And we're then being able to look at these outcomes at different times. We're doing things that are similar into the baby study, and you can certainly participate in both the baby study and the testo study. This is a little cute little baby in the pea pod, so you can see what that looks like. And the Trixie study is trisomies of X and Y chromosome variations. This is led by our colleague, Dr. Sophie van Ryn, over in the Netherlands. The aims of this study are to look at neurodevelopment in young children with trisomies, so XXY, XXX, and XYY, from 1 to 6 years of age, and to identify predictors of outcomes in social development, language, and behavioral regulation. So kind of in a different, not necessarily in the cardiometabolic health realm, but certainly very important as well. And we're enrolling kids 12 to 5 years of age to participate in this study. They do not need to have a prenatal diagnosis. They can be diagnosed postnatally. We're doing developmental assessments, and then we're also looking at eye tracking and physiology, so some heart rate and skin conductance while looking at certain videos. So in summary, these are all of the studies that we're currently enrolling for and engaged with. And if you're interested in participating in any of them, you can email extraordinarykids@ucdenver.edu. It's on the Access website as well, and a phone number to contact us. We'd be happy to talk to you more about these studies and get you more information and whatnot. Kids can participate in more than one study if they're eligible. They don't have to choose one out of the 3. They can do all 3 if they wanted. There is a little bit of a travel budget that we have to come to Denver, and all of these studies are actively recruiting right now. So my take-home messages for this talk are that X and Y chromosomes variations have an increased risk of cardiometabolic conditions. We know that there's a higher body fat percentage, and it starts at a pretty young age. We also know that there's poor fitness, but that we can intervene with exercise and then in the right situation, potentially testosterone as well. We also know that the risk may be reduced or likely is reduced by being proactive. And so getting regular physical activity, having a healthy diet, maintaining a normal weight, diagnosing and treating any medical conditions that may be present, and certainly advocating for yourself or your child, depending upon the situation, and then consider participating in research so that we can all learn more about how to help kids with X and Y chromosome variations, and teenagers and adults as well. So I have a lot of huge team of people to thank, and that are hugely important, and why I'm here giving you this talk right now. I also have a lot of funding sources to thank as well that are listed on here, and then I want to give a shout out to Access and for putting on these webinars, and certainly all of the patients and the families that participate in our research and that come to our clinic and that make my job so worthwhile and awesome. And with that, we'll take any questions, and you can certainly email me at shanlee.davis@childrenscolorado.org if you have other questions as well.
Well, Dr. Davis, thank you so much. Would you repeat that email address again, a little slower?
Do you see it on the screen, Robbie?
There it is.
Okay.
Thank you. Shanlee.davis@childrenscolorado.org. So we do have a few questions.
All right.
What do we know about life expectancy for those with XXY?
Great question. Life expectancy is pretty darn good. It's about 2 years less than the general population, but it's certainly not a life-limiting condition by any means. I think that the more, the thing that we certainly kind of worry a little bit more about or think a little bit more about is not just the life expectancy or the number of years you live, but the quality of life in those years and the kind of what we call morbidity of the other conditions that you have and you live with. And cardiometabolic diseases that we talked about being kind of some of the big ones that we think about as kind of decreasing that quality of life.
Okay. A mom wrote in wanting to know how can she help her 17-year-old son break habits that have been with him for much of his life, bad eating habits, and have gotten especially worse in the past few years. Any thoughts on that?
Yep, it's a hard cycle to break for sure. I think that there's obviously, it's easier when you have more control over them, when they're in your house all the time and you have, control over what they eat and what they do and what they watch and things like that. But, when they're 17, I understand that a lot of time is spent away from the parents. And so it's really hard to have them make good choices when you're not there kind of over their shoulder. I would say that putting limitations on where you can put limitations and kind of putting your foot down where you can put your foot down is really important, and probably the only way that we're going to get that motivation to actually change or to make a difference in breaking that cycle. And so when they are home, making sure that there are, rules surrounding electronics and TV time and things that need to get done before screen time, including physical activity being a big one about that. When they are home, not having access to all of the bad things that you can eat, presumably you're still buying the food, and so either not buying that unhealthy food and having a lot of healthy alternative snacks that they can have, because they're still obviously going to be hungry, and that's, eating isn't bad itself, but it's what you're choosing to put in your body that's important. And then, I do have some parents that have truly resorted to locking cabinets and things like that so that there's not eating, particularly at night, late at night, waking up or staying up really late and eating a lot of junk food at night. And so sometimes even locking that stuff up, if it is in the house and it is accessible, are options. And then, really positive encouragement as well. Those were all kind of negative things. Don't do this, don't do this. But really positive encouragement for when you do see them making healthy choices and taking care of their body in different ways. And I think that that's also really encouraging. I think a lot of times these kids hear a lot of things that they can't do or that they have to do, and sometimes we forget to praise them for the things that they are doing, even if it is small. Making baby steps is important.
Those positive comments might be more appropriate for this particular situation where the individual's 17 years old, and some of the don't do's are probably harder to implement with a 17-year-old than they say are with a 7-year-old.
Yep. I would say along with that, potentially if you do have a good relationship with their friends or their siblings, sometimes hearing messages, not necessarily messages, but, doing physically active things and making healthy choices sometimes can be heard better coming from peers than coming from parents when you're a teenager. So enlisting other people too.
Okay. This writer wants to know couldn't the increase in BMI be attributed to going away to college, sedentary work, playing a lot of computer games, driving motor vehicles? Thoughts on that?
Yeah, I think it definitely can. I think that we certainly see a drop-off in physical activity level as kids transition out of high school. Maybe they were playing sports in high school and then they stopped playing sports. Either they went to college or they didn't, but they overall adopted more of a sedentary lifestyle. And I think that that's a huge reason. I do think that I've seen a lot of kids, or young adults, I should say, that have a rapid increase in their BMI kind of at this age without a big change in their lifestyle. So it's possible that their metabolism is drastically slowing down at that time as well. And I don't know that I don't have any research to show that at this time, but I don't think it's always just the lifestyle choices that they're making. I don't think that there's always a sudden change there. I think that there might be something biologically kind of putting them at risk, but kind of that means that more proactive prevention and knowing that that's a risk is really important to combating it.
Have you heard parents, or actual, and for that matter, individuals saying that testosterone makes them more anxious or even prone to anger, even though their T level is only in the low 300s?
I have heard testosterone affects people in many different ways. And so I hear from my patients sometimes that they don't like how they feel on testosterone. Sometimes that is not necessarily the absolute level of testosterone, but sometimes the change in testosterone levels. So I'm thinking of, in particular, sometimes injections, especially if you're getting a bigger injection only once a month or once every 2 weeks or 3 weeks, because then you're experiencing more highs and lows, and that change in hormones can sometimes produce more irritability that we sometimes will see. What I do in those situations is trying to get the levels more steady. So I don't necessarily, again, care about the absolute number per se. So a level of 300, I don't know when that was taken. There's a lot of variables. Our assays to measure testosterone are not super fabulous and have a lot of variability as well. So I really listen to my patients of what they're experiencing and when they're experiencing it, and try to dive a little deeper if it truly is associated with testosterone, trying to maybe try alternatives to different formulations of testosterone or different dosing. For shots, I prefer actually weekly shots at small doses to keep the levels nice and even, as opposed to the kind of bigger shots less frequently, especially in those situations where the patient is telling me that they feel different when they're getting their testosterone. For the most part, the large majority of the patients that I have do not experience an increase in anxiety or irritability or aggression. In fact, I think that a lot of the times, if you are deficient in testosterone and we replace testosterone appropriately, a lot of those things can actually get better. So sometimes less anxiety and less irritability. And I guess that would all be in play if I'm seeing anger, irritability, anxiety. I would be both asking, is it too much testosterone or is it too little testosterone, and what is the best administration, or a lot of times not related to the testosterone at all.
All right, thanks. Any more that you can say in regards to girls with trisomy X? Any more specific advice than what you already shared?
Well, I don't have any truly specific advice, because we don't have a lot that we truly know about girls with trisomy X. And I think that knowing that we do see an increased risk in those mortality studies of deaths from cardiometabolic diseases, I think we need to certainly still keep it in mind, and that they may have that higher risk that we talked about in this whole presentation, and that a lot of those things can apply, being proactive can apply to any of the X and Y chromosome variations as well. I hesitate a little bit, because we do know that sometimes premature ovarian insufficiency or premature ovarian failure is more common in XXX individuals, particularly though in adulthood, not necessarily in childhood that we know of at this point. And so we know that estrogen deficiency, so if you have premature ovarian failure and you're not making estrogen, that does have the same risks that testosterone deficiency does from a cardiometabolic perspective. And so we know that low estrogen levels, you can think about women that have gone through menopause are at a higher risk for developing belly fat and these higher metabolic risks as well. And so whether or not that plays any role, so whether or not hormones play any role in girls with trisomy X, I think is a huge question that we still need to do a lot more research in.
Okay. If you have a family history of any of the cardiometabolic syndromes, is risk compounded? And if yes, by how much?
Well, that would be a great question to be able to quantify and answer. I will say yes, it is definitely compounded. That's one of the first things I do, is take a family history, because if you have a strong family history of, obesity and type 2 diabetes, and then you also have XXY, those are really the kids that I see that are that I would see that actually develop type 2 diabetes in childhood even. And so those are the high risk kiddos or individuals. And so a lot of things play into that. A lot of it is, other genetics, other genes that are not on the X and Y chromosome that confer risks that we see in families in general. And then possibly also, depending upon the situation, maybe lifestyle choices within the family unit as well, and tendencies to kind of compound that risk from a lifestyle perspective too. So yes, to answer your question, it definitely it compounds that, and being more proactive in those situations is important.
So, Dr. Davis, that concludes our questions, and I just want to thank you again for such a wonderful presentation. Very helpful. Just let everybody know that Access does post these on its website, usually within a couple of days of the recording, so that you can go back and listen to it again, and it'll be in the library under videos. I also want to thank again Endo Pharmaceuticals and Roche Diagnostics for their support of the Access webinar series. And then lastly, remind everybody that you can see what webinars are coming next by going to our homepage. The next webinar will usually be posted in a rotating banner at the top, but down in the bottom right corner of the homepage at genetic.org is a button that says upcoming webinar. So you can check on that. We do have one coming up May 1st with Pete Wright of Wright's Law talking about IEP and 504 plans for students with X and Y variation. So thank you again, Dr. Davis, for taking so much of your valuable time to be with us here this evening. Good night, everyone.
Thanks, Robbie.